We're going to talk about TLICS versus the new AO classification, which is, really how we're starting to think about these classification. But we'll talk a little bit of how we evolved into that position. So when we look at these fractures, you can see there's a variety of patterns to thoracolumbar fractures, and keep this slide in mind because we'll come back to this shortly. I'm having a hard time advancing slides here, Ashley. Okay, so I think the role here, the role of a classification we need to keep in mind as we go is to describe the fracture, be able to communicate to others. To do this, it has to be relatively simple. If it's not relatively simple, it's not going to be very reliable. It has to be accurate enough to compare one item to the next, because if we're going to do any research or study these fractures, it has to be reproducible. And it should ideally help us determine treatment. Is the treatment non-operative or operative? And in probably the best of circumstances, can it give us the specific type of treatment? And are we able to prognosticate outcomes for our patients? So this is an example of a 57-year-old male in a small airplane crash who has perineal paresthesias, poor rectal tone, and some weakness in his lower extremities. And we're going to use this particular patient as we work through our classifications to talk about how this might be classified and how it would help us. And you can see this injury at L1 and some at T12. So go ahead back, please. So, okay. I'm not quite sure why we're having this problem. So this talk, we'll talk a little bit about the evolution. We're going to talk about how TLICS came into being and why the current AO classification really helps us advance the concepts of TLICS. Actually, I'm still, every time I click, I can't classify. I'm just going to say advance my slides if you wouldn't mind. So classifications go back many, many years. And you can see this evolution of classification. Go ahead, advance. What I find interesting, is that 50 years ago, we talked about an anterior weight-bearing column and a posterior tension band column. It's kind of two-column theory. And what's interesting is really that's what we've come back to. It was really the advent of CT that developed a three-column idea, because up to that point, we used plain X-rays and tomograms to try to classify our fractures, and probably didn't have a great understanding of the middle column and what made a burst fracture. So it was really Dennis's classification in 1983 with the improvement in CT scan that helped that concept. And we got stuck on this for a while. Advance. So Dennis gave us this morphological concept. And I think really these four patterns, we still talk about. It's very easy to talk in these terms of compression, burst fracture, which is really what came into play with that classification involving the middle column, flexion distraction, and fracture dislocations. Next. That was further advanced by the idea that some of these burst fractures are probably stable and some unstable. And, interestingly, we still kind of have this battle today over what burst fractures need to be fixed and what don't. And it was McAfee and this group that advanced that concept. Next slide. So a stable burst typically had minimal kyphosis, less than 50% loss of height, moderate to mild canal compromise, no neurodeficit, no posterior injury. Next. The unstable fracture tended to have a lot of posterior fracture, tended to have neurological deficits greater than 20 to 30 degrees of kyphosis, and this concept of greater than 50% loss of height and canal compromise. Next. Along that same time, we were trying to understand this from a mechanistic standpoint. And really, I don't know that this classification ever caught on very well. Next. In addition, other classifications came into being, such as what's often called the Gaines classification or load sharing. And really the idea here was around this time frame, we began using pedicle screws to fix fractures, particularly the fixator intern, which was a 5mm screw. And what we were seeing in some of these fractures is that the hardware failed earlier than full fracture healing. And so the idea was that maybe some of these fractures required anterior column support, and it was a classification to try to help give us guidance in that respect. And still probably has some relevance, but again, was really for a very specific concept. Next. The AO classification came about at the same time, and in typical AO fashion, they divided this into an A, B, and C with increasing severity. And it was basically injury to the anterior column in the way of compression or axial load, a posterior distractive injury to the posterior elements, or some type of rotational translational injury that represented fracture dislocation. One of the problems was it was broken down into 53 subtypes of injury pattern. Next. It did prognosticate. So one of the things we would like to do with the classification is be able to prognosticate. And you can see as we went from A to C, the risk of neurological injury increased dramatically. Next slide. If you looked at these classifications and see did they meet our criteria of reproducibility, you can look at the Dennis classification, and it was a little more reproducible, a little more intra and inter-observer agreement. But the AO classification, when you broke it down into 53 subtypes, had very little inter-observer reliability. In a simple A, B, and C pattern, it was okay, but it didn't fare well when you started to try to break down the subtypes. So all these prior classifications were based on morphology with mechanism in mind, but in reality, what drove treatment and what drove treatment even back then? Next. Was morphology, which is what we've been talking about, the status of the posterior ligamentous complex, which is really how we define stable versus unstable burst, and then neurological injury. So these were all absent from the classifications up to this time, okay? And they really had to be described separately. So there was no classification that brought all these concepts together, particularly the ones we considered important to drive treatment. Next. The TLICS was the first classification to do this. And so it was developed with that specifically in mind, with 3 common concepts. What was the morphology of the fracture? What was the integrity of the posterior ligamentous complex? And what was the neurological status of the patient? And a score was developed to help offer guidance. Next. So this was the scoring mechanism. More points were given for greater severity, and the determination was made that fractures below 4 should be treated non-operatively. Fractures above 4 should be treated operatively. And then there was this one oddball in the middle, which was a 4, which was typically a burst fracture that was neurologically intact, but had an indeterminate posterior ligamentous complex integrity. And really, in all honesty, today, that still is a source of concern. Next. This fracture went through a lot of validation, and when you looked at below 4 and above 4, it really had a fair number of papers written, including independent papers written that nicely validated the TLICS as a way of guiding treatment. So suddenly we had a classification that actually guided treatment, which is one of the things we talked about in the beginning that was important for classifications. Next. The trouble with it came with what did it mean to have posterior ligamentous complex integrity. And I think we could all recognize these ones that were clearly intact and these ones that were clearly injured, but there's a very large group in the middle that are suspect or indeterminate. Next. Next. So various studies looked at this, and one of the things that did become clear is our old criteria of greater than 50% loss of vertebral body height or greater than 20 degrees of lumbar kyphosis were not particularly predictive of posterior ligamentous complex. But if you had a translational injury, which really puts it into the fracture dislocation group, that was highly associated with an injury. Next. There were a variety of papers that looked at this, and probably I think the best paper really broke it down because we often see edema in the interspinous ligament. Edema in the interspinous ligament, edema in the subcutaneous tissue is not very closely correlated with a true injury. But if you see disruption of two black lines, one being the ligamentum flavum line at the base of the spinous process, and one being the supraspinous ligament at the posterior edge of the spinous process shown in this slide, that was very sensitive and very specific for disruption of the posterior ligamentous complex. So if you do see that on a patient who you're in question on an MRI, that is a posterior ligamentous complex disruption. Anything short of that is very hard to measure. Next. So if we go to our case example, go back again. Okay, move forward. So TLICS really began to fulfill the role of defining treatment. So suddenly we could put a number on and say these fractures should be treated surgically and these should not. And we could use each of the components to describe it to the next physician. In other words, if you told a physician, I have a 6, that didn't mean anything. But if you told him you have a flexion distraction injury with clear disruption of the posterior ligamentous complex that's neuro intact, you could use it to describe it. But it was really more of an injury severity score. Next. Can you share that picture with me? Okay. So if we go back to our patient, we say, how's this fit in a TLICS score? Next. And we look at our components, you can see this looks like a burst fracture. It looks like it may have disruption of the posterior ligamentous complex. You can see in the back. Next. And so this was a dentist burst fracture, but really in the TLICS, it got 2 points for a burst. It probably does have disruption of the posterior ligamentous complex 3, and it had an injury to the cauda equina, which gave it a 3. And so this would be an 8 in the TLICS score. Clearly something that would warrant operative treatment, but if you told somebody this was an 8, it would be hard to sort out. Next slide. So what happened next was that because it was inadequate in being able to communicate, the AO kind of combined their old classification with the TLICS concepts and came up with a new classification. Next slide. This was it simplified the morphology from the AO to say A0 is where we put simple spinous process, transverse process fractures. A1 are compression fractures, whether it's superior, inferior end plate. A2 is a specific type of fracture called the pincer, which I'll show you an example of. And A3 and A4 were burst fractures. These were all the axial load injuries. And A3 was simple superior end plate, A4 superior and inferior. Next. The B fractures were those fractures that were in flexion or extension. So a B1 fracture was the classic bony chance, pure bony flexion distraction injury. A B2 was a flexion distraction injury that at least part of it failed through the ligamentous structure. And a B3 fracture were extension fractures that were incomplete, that didn't translate or go all the way through all three columns. And the C fractures were fracture dislocations, basically. And so they said there's no reason to divide those up. Anything that has translation rotation should be a C. And they said you name the fracture by the worst component. In addition, they added a neurological score. So it's almost like a tumor grading system. And it went anywhere from neurologically intact at 0 to an N1, which was a transient deficit. N2 were radicular symptoms, and then it had an N3 for incomplete, N4 complete, and an NX in case you were unable to assess the patient. And then lastly, only 2 modifiers. One of these modifiers, the M1, was that group of patients who was very difficult to tell if the posterior ligamentous complex was intact or not. And M2 meant that there were other things going on with the patient, other injuries that would alter your treatment. So it was just indicative that there were other concepts in play here. Next. So if we go back to those 4 fractures we saw in the beginning, next, we can see that this first fracture was an A2 fracture, the pincer fracture. And the reason this was important to subclassify is this fracture is a bad actor. The anterior inferior corner of the level above tends to collapse, and this tends to fall into kyphosis. So if you watch this patient on subsequent slides, next, you can see that the initial standing film's okay. At 2 weeks, however, it starts to collapse into more severe kyphosis. This is typical of pincer fractures, and it warrants its surgical fixation. So this is a fracture that we often operate on early. If we treat it non-operatively, requires very close follow-up. Next. Our next fracture was a classic A4 fracture, a burst inferior and superior end plate, no posterior disruption. Next. The next fracture is a type B1 fracture. This is also a very specific fracture, mostly in the pediatric population, seldom seen in adults, but it's one of the few flexion distraction injuries that can be treated non-operatively because it can be realigned and heal adequately. And you can see that on the following slides. Next. So this is a patient who we placed in a cast. You can see it has an anatomic reduction. At 3 months, it's healed and the fracture is completely invisible. Next. Oftentimes, we'll treat this now with a short percutaneous instrumentation system rather than a cast for ease of nursing care, and then remove the hardware at a later date. Next slide. You can see how this is done here, and the hardware is removed. And then the last fracture pattern would be your type C fracture. And these fractures give us guidance because they require multi-level posterior fixation. Next. Next slide. So if we go back to our patient and we look at this, it's really easy to classify this in the AO classification, and we could be very accurate and communicate. So next. So this is an L1 fracture that would be a B2 injury initially because it disrupts the posterior ligamentous complex with an A3 component burst involving the superior end plate. And it's an N3. It has a conus level injury that's incomplete. But we can also make note of the fracture below, which may change treatment by saying we also have an L2 A1 injury, or we have a simple compression at L1. So suddenly, if you said that, you could get a very good, clear picture of this injury. So, we need to achieve stability posterior due to the tension band guiding our treatment. We probably don't need any anterior column support for an A3, but we do want to actively decompress this because it's an N3. So we have a way of classifying it, discussing it accurately, communicating, and then guiding treatment. Next. And this is 3-month follow-up of this patient. Next. So we followed those concepts, followed the classification, achieved reduction, stability, all posteriorly, no need for an anterior procedure. Next. And so in summary, a classification, this is a classification that through the TLICS and now in the DAO is based on fracture morphology, posterior ligamentous complex disruption, neurological status, and it really is an effective tool for communication. We can compare similar fractures and really helps us determine treatment. So I would say that the TLICS is what led us the way, but the current AO classification is really the latest evolution and probably the classification we should be using today. And I apologize for the technical issues. I'm not sure what's happening, but I can't see the bottom of my slides to change them myself.
John, notwithstanding that excellent lecture, very definitive and in clarity unparalleled. So I want to ask Ashley to put up our questionnaire for everybody. And let's go to UCSF San Francisco. So Ashraf, what do you teach your residents and fellows now? What should they use?
I typically teach the AO spine classification. And we do discuss the TLICS classification, but with the idea that the main benefit of it is it really combined our, dictated that it's not just the fracture pattern, but also consideration of the ligamentous complex and the neurologic injury. So the TLICS is more so from a teaching perspective, but from a fracture management focus on the AO spine classification.
So we have an ARS question going on, AO spine versus TLICS, or teach both. Zach, how is it at WashU? I mean, here at our institution, we still get the Denise fracture, misrepresented, mind you, by many for fracture descriptions. Is that something that's just Seattle specific, or do you have that same problem?
I think we get some of that. I would say that we have adhered to the TLICS, but I'll tell you, after watching John's talk there, I think maybe a believer in converting to the AO spine, but I think we still probably are heavily a TLICS user.
So this is a big thing, because I think that let's see whether the voting is done. This is a close one. This looks more like our national elections here. The red wave against slightly wins, but let's wait for the mail-in ballots. So what I see here is 38% favoring TLICS over 34% AO spine, and to use both is 28%. So I think we can declare both a winner. Rick Sasso, are they actually complementary, or are they mutually exclusive? I mean, one is a severity scale, the other one is a classification scale. So you were in that initial spine trauma study group. What are your thoughts on this?
Yeah, so I don't think that they are mutually exclusive. I think they augment each other. I mean, the TLICS uses the AO classification system for its morphology. What the TLICS adds, just as John said, is the issue of neurologic deficit and the importance of that. It's incredibly important. And also the status of the posterior ligamentous complex. But the morphology, actually the fracture classification, the TLICS, is the original AO classification.
Final question on the subject, Baz. In the not so dogmatic German world, haha, I'm kidding. What do you teach now? What do you teach your neurosurgery residents in the University of Heidelberg as chief of spine?
We actually teach the current AO classification. I'm not sure how familiar the people here are with the TLICS. I'm not sure, like in Germany. So we, from the beginning, once it was published, teach the AO classification, and before it was Margau. So and TLICS was not so common, honestly.
So, John, you were a lecturer to the Society of Orthopedic Surgeons in Chile yesterday. And again, what is your perception on the international recognition of TLICS?
I think that, you know, if you go into South America, most of Europe, they were very ingrained in the original AO classification, so are much quicker to adopt the new AO classification. I think it's really an advancement of TLICS. I think if you look in South America, they're very used to talking in terms of A3, A4 fracture, B2 fracture. And so when we go to international meetings, that I think people are adopting that more readily.
So Zach, one more question about these severity scales. A classic problem when we have tripartite or more kind of severity ratings is that gray zone, that middle ground. Obviously, the larger that is, the more it lends itself towards kind of being the preferred response of people, and the less it helps us. Like the mandate that John said, it should actually help us drive treatment. So what are your thoughts in clinical reality? How often do you end up in that indecisive gray zone with TLICS?
I feel like that is the most common patient I see, that they're that TLICS 4, where it's the gestalt that's driving your operative decision. It'd be nice if they came in and there was, they were always greater than 4, 5, or 6. But again, my sense is, or maybe just what I've seen more lately is that they're always in that gray zone of 4.